because even myself, I was like, PTs do pelvic rehab, OTs don't. And I was wondering, how do I get into this with sex as an ADL across multiple diagnoses with bowel and bladder function, pericare, toileting, and hygiene? So, Whitney, you have been doing pelvic health, you just weren't calling it that.
Whitney, thank you so much for taking the time and speaking to me about just your journey as an occupational therapist and treating moms really acutely. And when I say acutely, for our listening audience, this is within days to weeks of their birth. Is that right?
Mhm.
Yeah.
Yes.
When you hear um, kind of the responses to occupational therapy on the maternal care team, what's come up for you in terms of just the public's perception, the healthcare system's perception of the role of occupational therapy at this time of life?
So, I am currently working in an inpatient rehab setting. And just to be clear, we are a three hospital system, like our hospital system, it's a level one trauma center. And there's like the main campus, and then there's two um, other campuses. So one of our campus has rolled out the acute care um, obstetric rehab program. They're in the growing phases. Um, that's not on our main campus. I am on our main campus and I'm in our inpatient rehab. We have had um, traumas come through that are pregnant, traumas that have come through that were pregnant and had to have emergency C-sections or experienced loss through their trauma. And my role on our team is as a float therapist. So I'm not a primary therapist. I only work part-time, but I'm trained on all of our floors and in all of our units. And so I am not on a maternal healthcare team per se, but I do know a lot of the teams and a lot of the providers through my role because I've been there a while. And when I do come up on a case, I find that I'm the one advocating for maternal and child health. I think that it's not innate for people in their training, for any provider in their training, to address those issues unless they are the OB. And I think that the OB on board is usually the only one talking to mom about her experiences with baby. Um, and even then, I think that the providers aren't asking, "How are you, mom?" And so I think that that is something that I continue to try to understand a little bit because I've walked through difficult pregnancies and, I've been followed by OB, I've been followed by maternal and fetal medicine and had a pediatrician like all on the same team. And I'm like constantly like, who's taking care of me and who's taking care of baby? Right. I think it's OB is me, maternal fetal medicine is baby before birth, and pediatrician is baby after birth. Um, but a lot of times everybody stays in their lane. And I think working as a team needs to be a little bit more involved and intricate with other players like us.
Well, Whitney, I want to piggyback off of that because you said that as the OT on in those cases, especially,
Mhm.
I mean, the trauma cases, right? During pregnancy, immediately after, you were the one that was caring for the mom as an occupational therapist. What did that look like?
Um, so usually in my chart review, I would notice with sensitivity that the mother was a mom going through this. And as a mother who has walked through difficult pregnancies, I have had four boys. Um, I would enter into that. This is what it would look like is I would enter into that. Hi, I'm Whitney. I'm your occupational therapist for the day. How are you doing? And we all know that we establish rapport with our patients. We read their plan of care, we read their charts. And what I love about being an OT is we get an hour to 2 hours with our patients in the setting of inpatient rehab. And so after establishing rapport, kind of shaking out like, how are you really doing? And like knowing those questions as somebody who's walked through it, like, so how are you healing after your delivery? Um, how is lactation going here in this setting? Have you seen your baby at all yet? When was the last time you saw your baby? And, walking through these past few years with COVID, I mean, it's just been very interesting when moms land in inpatient rehab, how that's handled. Um, so then usually it's a very significant, what I chart as a significant emotional event, because the mom just like usually loses it because she's so grateful that someone's asking how she feels. And then it's usually me walking away from our session, how am I going to document that? Because we talk about energy conservation, we talk about activities of daily living, we talk about, everything from how like cognition and how that's changed because of the trauma, to deep breathing strategies or ways to um, stay cool, calm, and collected in the setting of the crazy hospital environment and dealing with not being around the baby. And it usually is me walking away advocating for mom with our other healthcare professionals, to get other team members on board. So I know my float role that I might not ever see this mom again. So it could be me advocating to see mom again. It could be me getting rehab psych on board or neuropsych on board, depending. We have different rules for each of those disciplines getting on board. Um, if it's significant, like cognitive dysfunction, then maybe it's a speech evaluation. So we have special rules on whether or not speech is going to get involved. Um, it is, talking to the doctors that round. So they round once a week, but we have like sticky notes and our epic charts. And so it could be like writing a question like, mom, stated this. Could we follow up from a medical standpoint? Because I'm not the primary therapist, it may be me speaking to the primary therapist. Hey, could you speak up in rounds about mom brought up this mental health concern? Mom brought up, how she might need a spiritual care consult, or mom might need a recreational therapy consult because she would like to have time with a provider that would help her creatively think about ways to engage with family at home because she's missing her children and she needs help giving them words for what she's going through. And so it's really neat to then see everybody say like, oh, now I know what to do, or, seeing the benefit of that. And usually I catch mom and mom's really grateful that she didn't understand that we had all of those opportunities in the hospital. Um, but I think it starts with just like asking mom how she feels. And we do have great providers. I think we just don't have clinical practice guidelines for this situation. Obstetric rehab. If I say that, I think somebody would be like, what's that? It's like so new that even that coined phrase, it's wonderful that it's happening, and I'm here for it.
So a question on that, because when you first started out, you actually said, sometimes I'm walking out of the room and I don't even know how to document all of that.
Mm-hmm.
And I've had this thought, and I used to use the term imposter syndrome. I stay away. I actually run away from that term because it's anything but. There's imposter syndrome is not even the issue. Is that I didn't have the means of documenting what I was doing because my roots weren't embedded in my training, wasn't embedded in mental health.
Mm.
In rehabilitation, and what a lot of people, I think, that we've collaborated with, a lot of healthcare providers, is they're familiar with physical therapy. They're not familiar with occupational therapy. And just to divulge a little, personal story, I was not prepared for bereavement rehab on the maternity unit. The first time I walked into a room, one of the first patients that I actually treated was a physician herself. And so she had had a cesarean section, but her infant had passed away and was in the cooling bassinet. And I was in a swirl of uncertainty as to my capacity to really support her through a recovery, a successful recovery, because I knew that there were so many missing pieces, and I could teach her how to log roll out of bed. It's kind of what baseline. I knew I could do an abdominal surgery recovery protocol, but would I catch all of the things, all of the emotions that she was also going through, the tone in the room, and then the occupations that she was going to have to encounter at home without having that adrenaline rush that mothers get to help them bond with their baby and help them heal and help
Mhm.
mitigate their pain. I knew that was not happening hormonally in her body. And so there was a list of uncertainty that I was going away with after that experience of how do I document all the things that wasn't necessarily embedded in my training, but I knew needed to be done, and to
Mhm.
address overall occupational impairments that I knew that anyone after an abdominal surgery would have, just the sheer difficulty of just standing in a hot shower. Like we don't think about those things and those questions to ask on the maternity unit, but in the setting of losing a baby. I don't think bereavement rehab, maternal health rehab, obstetrics rehab is being loud enough on the maternal care unit to help people understand there's a bigger pie that we need. If the
Mhm.
pie right now is divided onto only so many care providers, then we need to make that pie bigger to accommodate occupational and physical therapy on the maternity unit. And so when you said that, Whitney, it struck a nerve because I feel like you're the most appropriate rehab provider to be on the maternal care team. What would you say in response to that?
Where do I start? I'm smiling because from this conversation, I'm grateful to be here. So I've been that mom. And you and I know from previous conversations that so say that I've had four. I get asked all the time, how many children do you have? I have had four boys. My third son was had a prenatal diagnosis. And so that was a palliative pregnancy. So there's another term that we're not familiar with usually. I chose to carry him until natural death, and then he passed away at 34 weeks from one of his conditions, which involved his heart. And I had a vaginal delivery, an induction, and delivered in the hospital. So we did have cuddle cots. So in that hospital, so that's the cold bassinet that you were talking about that you witnessed. Um, and I remember thinking that where is therapy, right? Where is therapy in this situation? And then later, 3 years later, I had a fourth son, and he was my first C-section. And I remember thinking, where is rehab here? Because I couldn't. It was hard to get out of the bed. I felt like a pro at nursing by then, but I couldn't do it in all my familiar ways because of my C-section. So I had to learn new positions and figure that out. Now I am familiar with being in the hospital because I work in one, so I knew to ask for lactation or, to advocate for support and for self-care. But what do moms do who don't know who's available or how to ask for help and are just stuck in those emotions that happen whether you're bringing your baby home or not? The wave of emotions, the wave of hormones, the depleted iron levels, the nutritional deficiencies, all of that play into the level that mom has to cope with whatever it is she's going through, whether that's transitioning home as a new mom, transitioning home as a mom of multiple children, transitioning home as a mother who is now going through postpartum without baby. And then people don't even recognize that she's going to lose her hair and have lactation and all those things that moms usually go through. But to do that without your baby, Um, so I think that um, where is rehab was what kept resonating with me. Um, and I do, I'm grateful that as a PT that you're recognizing the role of OT, because even myself, I was like, PTs do pelvic rehab, OTs don't. And I was wondering, how do I get into this? Because I felt like there was a place for OT even amongst pelvic rehab. And as I continue to learn more about what enhanced recovery after delivery offers and more about pelvic health and following people, it is phenomenal field for OTs to be in. And I have a lot to learn. So I've been a therapist for 10 years, but I'm so excited to learn new stuff about how I can help moms before, during, and after delivery, whether they bring their baby home or not. So, um,
Whitney, that was your, I'm going to just say that quote, was that the running tagline that PTs do pelvic therapy, OTs do not? Was that a running tagline before your own experience or before even treating moms in the hospital, or is that still a running tagline for you?
you
PTs
know,
do pelvic therapy, OTs do not.
it has changed for me in the last 6 months. So I would say until my fourth child did I realize that OT could have a place, could, like that I could, as an OT, have a place within pelvic health and that OTs were already doing it. So, like, I did not know this until my fourth child, which I think is like, I mean, I'm not like a new mom, and I've gone through pelvic health with all of my children, and I've never seen OT showing up for it. And so I think that that natural, it's kind of like there are little pockets in each of our fields, right? Like sometimes if you hit vision, it's OTs doing it. Sometimes if you hit pelvic floor, it's PTs doing it. You lymphedema, I feel like I think PT, but I've done it as an OT. So it's just kind of like, and then that can even vary from state to state. So I think,
Community to community. Yeah,
yeah.
like who you surround yourself with. So I'll counter kind of that tagline. I think that's probably running through a lot of people's minds. Like I'm so glad that you're actually being just transparent and just saying what you have experienced in your own practice. But in my practice, before I actually went through formal training as a physical therapist and as a pelvic health therapist, I first was introduced to pelvic health therapy by an occupational therapist in inpatient rehab. Now, the
What?
case was not maternal health. The case
Okay.
was a woman who had a C6 spinal cord injury who wanted to know, could she still bear children? Could she still have a sexual, fulfilling, intimate relationship?
Yeah.
Probably is a more appropriate term, because intimacy spanned so much. It spanned a lot of mental health and a lot
Mhm.
of emotional connection with her partner. And the occupational therapist was was teaching to such a level of detail that I didn't even realize that their scope was that huge. Uh,
Mhm.
not only
Sex
that, I
is an
mean, just
ADL. Yep.
it is the peri care that she taught other patients that I was trained really by occupational therapy. The road to physical therapy was completely an arrogant one. I saw the doctorate and I was there, but so much of my training after that, even when I did start practicing, was again through occupational therapy, lymphedema therapy, genital pericare,
Mhm.
especially in the lymphedema world. Inpatient was all occupational therapy ran. They did all of the pericare after cesarean hysterectomy. Unfortunately, if the labor and delivery process involves postpartum hemorrhage, the patients that I saw who had to navigate their recovery with a Foley catheter, Whitney,
Mhm.
after either an unexpected hysterectomy at the time of their birth and then navigating that and the pain of their first bowel movement, again, I learned some of the best techniques from occupational therapy. So when I hear that, of course I had a knee-jerk reaction. Physical therapists do pelvic therapy, occupational therapists do not. Yet all I've seen professionally has been the opposite in terms of the acute environment, the acute period of time that people are in a state of shock, like so uncertain about how they're going to do and manage all of this at home. And it's the first occupation they have to do is void their bladder, empty their bladder, and try to have a bowel movement. And occupational therapists, to me, are the priority rehab team members on the maternal care team. I can't unthink that. And so a
Mm-hmm.
lot of our publications have led with occupational therapy because I want people to understand it's more than an alphabet thing, O before P. This is more than me choosing to list them first. It's because I see them first. I see them as addressing what we need to do to live in our lives.
Mm-hmm.
All the roles of an everyday life. What does that look like? That's occupational in nature.
So, first of all, thank you for validating that I'm already doing pelvic health because I've been questioning that within myself. And I think that like if I think that as an OT who's been practicing for 10 years, I wonder what our patients think too when we say pelvic health, because I'll be honest, when I think of pelvic health, I think of internal pelvic health and not just what OTs have been doing, like you were saying, with the education surrounding like the Plicit model with sex as an ADL across multiple diagnoses, with bowel and bladder function, pericare, toileting, and hygiene. So I think that I need to just give myself that mantra. Whitney, you have been doing pelvic health. You just weren't calling it that. Um, and when I say I have a lot to learn, I do, because there's a lot of anatomy there, a lot of language surrounding the pelvic floor, the pelvis, and a lot of the more internal stuff that OTs don't necessarily have coming out of school, like that training. And I know for even therapists who become pelvic health therapists, that's all continuing ed. Like we can't learn everything in school. But I think that that is eye-opening. And I think that I agree with you that getting up, taking those first few steps, peeing and pooping and showering in the hospital are all ADLs that moms usually do before they go home. And if they have a problem with that, then that should be a red flag for going home, for discharge or having home health follow-up.
Yeah. I often think we've encountered this on the acute care side, and I know that your background has been in acute care, and I want to talk a
Mhm.
little bit more just about your transitions between all these different settings. Like you have such a depth and breadth of knowledge of just the patient journey, right? You know, acutely, the patient journey before they go home, what that really looks like. And I want to unpack that a little bit. I will say that I encounter that on the healthcare provider side far too often is their pushback to even having an occupational therapist or a physical therapist on the maternal care team in the hospital is because they're confusing the intervention with the discipline.
Mhm.
And so the intervention of internal pelvic floor assessment and treatment is not indicative of the discipline, right? It's an intervention. It's an intervention. It's like a tool in your toolkit. You know, do you also do lymphedema therapy? Do you also do manual um, uh, uh, I'm thinking of muscle energy techniques or craniosacral therapy or whatever intervention you want to use. And I
Mhm.
found that in my own practice as an outpatient pelvic health therapist or women's health therapist, I had the intervention. I was trained on the intervention of internal pelvic floor assessment and treatment. I often did not employ it because so much of my population experienced trauma. And that was an intervention that was not appropriate to introduce an internal um, assessment and treatment with someone who had experienced trauma through those invasive means.
Right.
And so in the hospital, it made perfect sense that I could still bring in my pelvic therapy skill set, but not use the intervention of an internal. exam and treatment, but
Correct.
still address all of those pelvic health functional things that the whole system is now being challenged to do. And I found that nurses historically were taking vital signs at rest.
Mm-hmm.
And it was from an occupational therapist, Whitney. I kid you not. It was from an occupational therapist that I learned that showering in a hot shower involved more METs, metabolic equivalency of tasks, than walking, than even going up and down stairs. It was
Yeah, showering's
showering,
exhausting.
exhausting. And I would hear from women later on who had lost considerable amounts of blood during delivery that that was the hardest thing that they had to do was taking
Mm-hmm.
a shower. And so again, I go back to the pelvic health therapist, the maternal health therapist, the obstetrics rehab therapist, however we're going to call it. We chose to, as an organization, recognize these professionals as perinatal health specialists because we felt that their role encompassed more than just the interventions that we could teach them in the room, more than the maybe pelvic health skills that they had on the outpatient side to really address the journey of the postpartum mom. We felt like they were able to identify things, collaborate, and communicate with the entire care team at a level that your staff therapist may not have been um, working at. And I say that, very intentionally because I feel like we, as rehab providers, educators, are graduating our therapists to be more like technicians. What can you do? What productivity can you do those things and operate at? And that's not a therapist that we want to be sending into the room of a woman who lost her baby to see if she's up and moving, walking around. Can she do the impact 6 clicks score? Can she go up and down stairs? Are her vital signs stable? We needed more of a specialist that understood the holistic, the continuum of care. And so I really leaned heavily on the training of occupational therapists, but then also on the ability of someone to communicate. And so I want to talk and wrap this full circle with your training, with your background. What do you foresee in terms of maternal health areas that we can really fill the gap in terms of the care that people are provided after birth? What do you want to do with what you have?
So, um, I I really like how you explained the term that you all are using of perinatal health specialist and how that encompasses so much. So I'm really glad that you opened my eyes to why it was named that, and I think it's very appropriate. Um, where do I see OT going, or is your question like where do I feel like OTs could best serve, like in like
Oh
setting wise?
no.
Here,
Whitney, I want to know
state the question again.
what you want to do with your skill sets. You've been an acute care therapist, an
Hmm.
outpatient health provider, an inpatient provider who's seen
Yeah.
moms who needed more extended care, either after losing their baby or being pregnant or,
Hmm.
having their baby. You've seen it all. And so what do you want to do in terms of maternal health or rehab for this population, early, later on in life? Where are you going? Where can we follow
So
you?
what I would personally like to do is see patients in the home 0 to 6 weeks after birth or virtually. Um, and I think that both could happen simultaneously, and that's what I'm trying to create. So I've recently started a private practice, and will also be underneath an umbrella of a virtual hospital system. And through those two platforms, I hope to treat both in the home and virtually. The reason I think 0 to 6 weeks in the home, which is going to be pushing against the grain a lot and doing a lot of networking, is because I think that therapy needs to start before the 6 week checkup. I think that those 0 to 6 weeks are vital to catch, you know, any type of decline in mom's health, I think it is the time to step in from a mental health standpoint, from functional movement after birth, like not feeling stuck in the chair, nursing all day, not feeling stuck in the bed because you can't get out. Um, and even, I mean, even feeding, I even know from like my personal C-section story, all the little movements to get your body to the table, just to bring your fork forward. I was like bringing the fork here to my mouth from like, because I couldn't access those abdominal muscles to lean forward. So all of the adaptations in the natural environment, in the home where they're going to be, is where that meaningful occupation is going to be most impactful. So helping them increase their confidence in the transition of their roles and their habits and their routines. And that's kind of how I document it. To go full circle is I add it with their roles, habits, and routines onto about every sentence. No, not every sentence, but that really sums it up. And so just increasing the family education, the spousal education. How can you support mom in these transitional movements? How can you support mom with the bathing and showering? How mom can support herself with positioning for feeding. And then just networking from there, noticing if mom needs lactation, noticing if mom needs OB appointment sooner and advocating for that. Noticing and referring to providers, you should probably be following up with outpatient PT, for X, Y, and Z. So I think that it's a good place to be an advocate, and I think it's a good place to start for the continuum for OT. So I do also feel like it's going to need to back up, because we're going to need referring providers in acute care to acknowledge that they're going to need home health from 0 to 6 weeks. But once we let people know we're here, I'm hoping that through word of mouth, people want it for themselves in the home, and that they realize that they can ask for it. And so that's where just being providing education and that health literacy in the community is going to need to also increase. So it's a big job. It's a lot of work.
It's a lot of work. And I think I recognized early on, Whitney, that we can't do this and we cannot be um, a single organization doing this alone. The reason why we landed on probably perinatal health out of maternal health rehab specialists, out of obstetrics health rehab specialists, is that we wanted to really convey that a lot of this work started during pregnancy. And
Mhm.
a lot of our moms are sitting in uncertainty on high risk pregnancy units. And the
Yes.
workforce that we had, Whitney, were those therapists that could access them in the hospital. And those were our acute care therapists. So we had to choose very intentionally a name that could, one, designate the role of an acute care therapist or a home health therapist or an outpatient therapist, wherever, regardless of setting, a virtual care therapist to be
Hmm.
able to address the needs of a mom who's still pregnant, maybe with a high risk pregnancy, maybe with a baby who has life limiting diagnoses,
Hmm.
right? As well as carry that care on to the postpartum journey, which is not a period, it doesn't end. It's a journey that women after baby is born experience for the rest of their life. In some cases, they experience
Yes.
those changes that don't necessarily go back. And so, for for me, hearing you say that this is a big job, but then the fact that you are choosing a mode of delivery through virtual care, I
Hmm.
want to pull something from our current curriculum that I think will really help the audience understand the significance of that. One of our instructors, Dr. Joanne Michelle Martin, actually said in a recent module that she operates in a state, the state of Georgia, that has about 72 to 73 counties without an OBGYN. Maternal care deserts, I believe I read a stat, make up uh, at least over 50% of the states uh, have maternal care deserts. When you think about like just the sheer vast amount of populations that don't have access to maternal care, think about what you can do through virtual rehab,
Yeah.
especially in the first week, not 0 to 6 weeks. We know that statistically, most of the complications happening after birth are occurring in the first 42 days. What you're talking about are occupational impairments that moms are dealing with within the first week, moving just to bring food to your mouth after you've had a cesarean section and no one's even probably talked to you about just the abdominal recovery that you'll have to do ongoing in the setting of newborn care. That to me was like, that struck a nerve right now. Like that just made me think of yet another avenue that we're not addressing in our curriculum that has to be addressed from the acute care side, only the acute care side. We can have pelvic health therapists trained, Whitney, in the outpatient setting, but when you go into a birth and you're not expecting to have it go sideways and have an
Mhm.
unplanned C-section, it's the acute care therapist that we have to train. And I feel
Mhm.
like it's our perinatal health specialists who are going to have more information and knowledge to make that connection with an acute care team and with the outpatient individuals. And that's exactly what you were speaking about, being a referring partner, right, on the team who's able to recognize everyone involved. I mean, I can't think of that being at a staff therapist level. That's a higher level of thinking and navigating and collaborating, right?
Yes.
And you're already there.
I'm glad
That's
you're
exactly,
recognizing it
you're
because
already
sometimes I don't
there.
feel like I'm there.
Yeah, I don't believe in imposter syndrome. What I do believe in are barriers to equity. And barriers to equity will make you feel like you're not fit for the job, right? Whether it's your own history or whether it's just what we see as systems of neglect, is that when they're so huge, I mean, getting a program started in a hospital is a huge thing when you have a whole team saying your services are not necessary. And I've had that as a physical therapist, wanting to enter in and really provide care as a rehab specialist on the maternal care team. To be said that makes me think imposter syndrome. And I have to take that thought and get it as far away from me as possible because, Whitney, that's not imposter syndrome. That is systems of neglect that are in place and they seem immovable and they make me question my own competency.
Hmm.
And so to bring this home, we had a very, for me, it was a very impactful conversation before we came on today about, I don't want to say it for you, but it sounded like you were dealing with imposter syndrome of bringing your own experience into this work and how that might impact you. After we've talked today, what are your thoughts now about that?
Um, I'm really excited for the support of this community that you've created. I'm really excited about learning more um, because knowledge is power. And I think having the language coupled with the advocacy that advocating for my patients is a strength of mine. And I think having the language and the educational piece to talk and to speak to a lot of these constituents at the table per se is where change will start to happen, changing people's thoughts or perspectives. And I think one of the things that I recently learned that I was sharing with you prior is these social scripts. And I think that it's a social script. A social script is something that I was coined by sociologists. And this is how it's been done for so long, and this is our response to the situation. PT and OT aren't part of it, right? In this social script, and we're rewriting it. And so I think that changing the social script it's going to take the language, it's going to take the education, it's going to take the advocacy, and it's going to take time. So I think that I'm empowered by the programming that you're bringing to the table. Um, and I'm excited to learn so that I can use my advocacy to make change happen, locally and virtually. So I'm looking forward to it.
I'm probably more excited than I've been in a while. And I told you this before we actually went on air. You are probably one of the best writers I've seen come through this program. And so when you said rewriting the social script, I will hold you to that. There is a case study that's a part of our program, and I cannot wait to read yours. I cannot tell you how excited that makes me because so much change, Whitney, in our history has happened through writing, right? So
Yeah.
many of the tenets of our culture and our morals are through the written word. And you have a gift that when you're ready to share it, I believe that it'll actually move these things along faster than we've ever seen. And that is rewriting history. That's rewriting the social script. So, Whitney, share with the audience where people can find you, where people can connect with you through your private practice, the organization that you serve with. How can people get in touch with you?
Yes. So you can email me at whitney.whitmore. So Whitney, WHITNEY Whitmore, WHITMORE at mycatholicdoctor.com. So that's the virtual hospital system that I am onboarding with. The email exists. I'm getting used to using it and hoping to go live in August, with treating patients. You can learn a little bit more about the ministry that I run at lotvministry.org, and that stands for Lily of the Valley ministry.org. So I do a lot of my bereavement work in that area. Um, yeah, I think those are the two big places that you'll find me these days, other than home with all my kids and their
Thank you.
summer schedules, summer camps. I've been in the
Absolutely.
car more today than anything else.
And just for reference, this has been recorded in 2024, but I think that your words will they'll reach really from for years to come. And I can't believe that that we have the honor of working with you and just seeing this journey unfold together. So
Thank you
thank you
so
for
much,
your
Dr.
time.
Peters. I appreciate the time.